One time, what we'll do is we're going to go ahead and start going through the non-action items. So I will go ahead and call to order them at 9:02. Good morning, everyone. Just a reminder that this meeting is being recorded. The recording is posted, so anything that is said or shared during the meeting will become part of the permanent recording on the ADHS website. Just a reminder, if you're not speaking, if you could please keep your computer or phone on mute. If you are joined by telephone and not by computer, you'll have to hit star 6 to unmute yourself. We will go ahead and try for a roll call once, and then we'll come back to that if necessary.
Andrew Tang. Anthony Griffey.
Here.
Brent Burgett will be absent. Brian Stevens.
Present.
Charles Hu. Cliff Jones. David Natrika.
Here. Present.
Thank you, David. Debbie Johnson.
Here.
Edgar Bissonette. Bronco Castramarin.
Here.
Gail Bradley.
Present, and I just have Brent Burgett joined if you would like to call in for roll call.
Brent Burgett, did you join the meeting?
Yes, I was able to make it. Thank you. I appreciate it. Thanks, Dr. Bradley.
All right. Garth Gamer.
Present.
Herman Butler. Ivan Pfizer fan. Nick Elf.
Here.
Narav Patel. Rod Reed.
Here.
Ryan Southworth.
Here.
Sandy Nygaard.
Here.
Sean Bowker. Sarah Johnson.
Kara, we can't hear you if you're speaking, but if you can put the chat for your attendance, we can capture you that way.
And Vicki Bennett.
Sure, maybe having audio issues. I don't see a microphone for her to light up. Oh, thank you, Tara. We see you raise your hand. We have you down for attendance. Thank you. Okay. I see 13. We have excellent. Thank you, everyone. For your chair report today, and I see Dr. Tang just joined as well. There is the attendance report. Just a reminder that if you missed 2 or more consecutive meetings, the Bureau will contact you to determine if you're still interested in participating in the committee. We'd like to welcome a few new members today. So first, Nick Ells, and then Dr. Ryan Southworth, welcome to the committee. So thank you both for being here today. We have several reappointments as well. Sandy Nygaard, Anthony Griffey, Dr. Garth Gamer, Dr. Natrika, Vicki Bennett, and Dr. Cliff Jones. So thank you all for your continued participation as well. We too have 2 vacancies. We have a representative from a statewide rehabilitation facility and a representative from Regional EMS Coordinating Council, Southeastern Region. For the Southeastern Region position, this is appointed by SAME. So if you're interested in participating, please let Sarah Parati know, and she can go ahead and forward that to our committee. If you know anyone that qualifies for the other position, please let them know to contact Shelley Bissell for addition to the committee. I just wanted to briefly cover as well. I know I've mentioned this in previous. Thank you, Dr. Hu. We have you down as present as well. I see several hands up. Dr. Hu, we've got you down. Tara. And then let's see, there is another hand. Corey, I see your hand up.
Do you have a question? All right.
Dr. Tang, do you have a question, or just letting us know that you're on for attendance?
Attendance.
Thank you so much. Excellent. So moving along on the agenda, just a reminder that the Bureau has been awarded another 4-year grant for the FR-CARE program, which is going to be addressing the opioid epidemic. This grant cycle is going to focus more on the naloxone leave behind program. Sebastian Thomas, who is with us today, is our lead for that program. We are very near our go live for that, so we are really excited that we are getting close. We have had a number of EMS agencies who have expressed interest in participating with the program. As part of that grant, we already have live the educational module. It's a very well-done module that is ready to go in any learning management system, so it's very easy to distribute to your agency and your personnel. They will log in, take the educational module, they get CE, we will be able to track who's completed that for you as well. Once you've completed the training, within the next 2 months, we should have the naloxone leave behind kits available. The kits are going to have a 2-pack dose of the intranasal naloxone in the pack, as well as specific resource guides for your jurisdiction or area. So we've really worked hard with the Center for Rural Health and University of Arizona to make sure that those resources are very relevant to the area where you're working. So when you request the naloxone kits, Sebastian will make sure that the resource guides you get are relevant for your community. There's also going to be a pamphlet of kind of information for the patient or individual who may be using the kit, of ways to identify the overdose, and also one to go for other resources. So all of that is in that. So we are very close to going live. Once we have the kits available, we will do some more advertising. We will distribute that via the Gov Delivery System, our EMS regional councils as well. So I just wanted to give a quick summary and update on that program. Next for the Bureau report, I will hand it over to Chief Garcia.
Thank you, Dr. Bradley. And we just have some slides that we will share briefly. In the interest of time today, I won't go in depth through all of the slides that we have available to share with you all, but do know that we will be distributing these slide decks to all of our statutory committee meeting participants today, and they do have quite a bit of information in them. One of the questions that we've been asked at Arizona Department of Health Services is to share a brief update on our organizational chart. We currently have an acting director, Jenny Kuniko, and underneath Jenny Kuniko for awareness, we sit, the Bureau of EMS and Trauma System rolls up, I know this is very small, but rolls up under the Public Health Services Division in the Department of Health Services. And for awareness, we will make sure that we continue to share our organizational chart here at the department. Some quick legislative and rule updates. We are tracking several bills that were passed last session and are making their way through the process this session. Of note, here you can see a handful from last session and this session that have links in them for any review. The ones that we have asterisks by include House Bill 2609 from last session, and House Bill 2589 and Senate Bill 1711 from this session. These bills have asterisks next to them because they will require rulemakings to update ambulance certification and training rules. We expect that we will be convening a work group again to look at these rules, and any draft rules that are posted, we will of course notify our statutory committees and folks that are subscribed to our listservs that there will be an opportunity for comment. Because of the way that these bills have passed, they will become effective January 1st, 2024. Senate Bill 1711 has not yet passed. I want to point out that that one is still pending, but from the notes and updates I've received so far, it does sound like that one is on its way to be passed when legislative session comes back, I believe on June 12th. So we are tracking those. We will continue to provide updates. And if you have any questions, please don't hesitate to reach out to the Bureau. We will keep everyone updated on legislative and rules as we move along here. Going to the next slide, Shelley, I don't know if it's responding to me. Oh, there we go. For this advisory board in particular, we wanted to make sure that we were reminding folks that we have the draft trauma rules posted for comment until May 21st. There is a link here to the website where the draft rules are posted. There is a stakeholder survey open for comment until midnight on the 21st. This is an expedited rulemaking that is based on the most recent 5-year review. The way that expedited rulemaking proceeds, it is not intended to be substantive. It really is to clarify and make the rules more clear and concise. So you will not note many, if any, substantive changes in the draft, but we are seeking comment on the current draft until the 21st. We want to thank all the staff members that have participated in the review process thus far. We notified staff in April and early this month that we had draft rules posted, and we really appreciate the feedback that's been submitted so far. I want to note that the end of the federal public health emergency declaration was on May 11th. And with that, at midnight, Title 42 public health order did sunset. We have been monitoring through the Department of Emergency Management and Military Affairs the situation at the border. We've been keeping in touch with our regional councils, and we want to encourage everyone to let us know if you do have any requests related to the end of Title 42, but thus far, we have not received any significant resource requests that I am aware of, and just want to make sure that folks know that if you have any questions, especially related to EMS and trauma post public health emergency, please let us know. There's some additional resources listed here, and we will make sure that all those links are distributed to you all. One of the highlights that we'll talk about a little bit more during our EMS council is the ongoing patient offload plan that is a collaborative between hospital and EMS providers. I just want to give a shout out to all of the folks on the hospital and EMS side that have been working together on this plan across the state. I'm going to keep moving on, and I want to give another shout out to our trauma providers, especially today. May is National Trauma Awareness Month. We know it's also National Nurses Month and EMS Week. So big thank yous across the board to everyone for the work that you do. On the EMS side, there is a proclamation that the governor issued for EMS Week that is May 21st through the 27th. You'll see posters up around the building if you're here at the Department of Health Services today. We've also recently posted a blog highlighting a partnership between Arizona Trauma Centers, Department of Health Services, and the Governor's Office of Highway Safety. This theme this month for National Trauma Awareness Month is Roadway Safety is No Accident. We have additional posters up around the building today that highlight Arizona crash facts, and we would be remiss if we didn't thank all of our trauma centers, the 47 trauma centers we have across the state that do such important work to make sure everyone stays safe and that we really are taking care of folks across the state. A reminder that we wanted to get out to everyone, and you'll hear us say it again and again today throughout the meetings, is that AZ Peers and BEMSTS version 3.5 reporting requirements go into effect on July 1st of 2023. I won't spend too much time on this slide today, but we want to make sure that all of the information listed here gets out to all of our providers, especially our EMS, air and ground agencies. And finally, opportunities for stakeholder input. We talked about draft trauma rules, and again, thank you to the advisory board for your input on those draft trauma rules. Other items to note are there is an EMS and trauma needs assessment survey link that is being distributed to all of our agencies, trauma providers, and EMS agencies across the state. We appreciate your feedback to help inform future strategic planning at the state and regional level. We'll also have additional draft rules posted for comment. Here you can see that there is an opportunity for comment on ADOT's 5-year construction program. And there's also a notice of funding opportunity for Safe Streets and Roads for All. Please take a peek at those if you are interested. And we're happy to share additional information if anybody has, if anyone has any questions. Dr. Bradley covered naloxone leaves behind, and we'll make sure everyone has Sebastian's contact information. And I will leave us with this, which is please remember to sign up for our self-delivery updates if you are not subscribed already. From there, I will hand it back to Dr. Bradley and the standing committee report. Oh, and thank you. Gail has reminded me a little bit later in the agenda. I believe we have it. We want to make sure, especially in honor of National Trauma Awareness Month, that we are taking time to really recognize the trauma centers and the trauma providers across the state. We would like to develop an annual trauma program recognition awards program. And that is something that we hope to discuss a little bit further as we make it through the agenda. But please know that it's so important to us that we take that opportunity, and we'll look forward to having some discussion on that today.
Thank you. All right, next for standing committee reports. I don't know if Sean joined us for a happy report.
I can do it.
Okay, thank you.
I need to get this little cheat sheet. The March 16th happy meeting, Melissa Lexon with Banner and Arizona Falls Prevention Coalition gave a presentation on strengthening falls prevention efforts with the help of first responders. They approved their November minutes. Foxhole County presented the Bureau's EMS annual report that contained 2021 data. Krista Wilson explained the data request auto set age groupings, and there is some flexibility for changing the age sets when you submit your request. The share user group was approved. The meeting date has yet to be set, and then they approved a work group to review the bylaws, and that meeting date is to be.
Thank you, Shelley. Next, Sandy for Education Committee reports.
Yes, the November minutes were approved. It was also approved for the FR CARA grant for the naloxone leave behind training as it was presented. You approved the training for the ASTRs for EMT airway for supraglottic and eye gel insertion as presented. You approved the updates for training, what should go into your EPCR. We did table the draft for PACES pediatric seizures and status epilepticus training. We added a topic list for future work group for fall prevention, mitigation training, and approved workshops to review the bylaws, but we have no meeting date set yet. That's the end of my report.
All right, thank you, Sandy. Next for PMD updates, Bronco, and I'm going to embarrass you by saying happy birthday for today as well.
Happy birthday.
Thank you for joining us on your birthday.
I timed it to EMS weeks.
Yeah, perfect.
Thank you very much. So we met on March 16th, and we approved the minutes from the prior meeting. We also approved the minutes from our special session on February 16th. And T3Gs were amended and approved in areas of OBGYN, as well as appendix and preface pages. We approved drug profile pages for ibuprofen and acetaminophen. We sunsetted the standing agenda item to discuss medical direction for hospital-based EMCT practice. And we approved the formation of a new work group to review the bylaws of this committee, but no meeting date has yet been set.
Thank you very much. Next, Shana for the Trauma Program Managers Workshop.
Hi, yes. The Trauma Program Managers Workshop was held on April 14th at Mount Graham Regional Medical Center in Safford. We had a bureau report from Noreen. One of our local surgeons, Dr. Marble, did a case presentation. Kim with the state provided us with an overview of the new trauma portal and the new application process. We had a couple trauma case presentations and a review of the hand-heavy program. And Micah White with Arizona Game and Fish did a presentation on ATV injury prevention. As a result of that, we're working with Kim Jackson with the Arizona Game and Fish to do more injury prevention related to ATV accidents, especially in the southern region, and use their program Quail Kids.
Thank you very much.
Yeah, thank you.
All right, next, Adam for PACES report.
Hello, good afternoon, good morning. EMSP Day is in the middle of EMS week next week, and so in honor of that, we are going to make live a link for Epic stickers, which is a brightly colored sticker with space for your child's pertinent information. So we'll be making live that link. They'll come in packs of 100, and that's for you to distribute to your first two. BEMSTS also has some education coming out soon that's going to be posted to the independent study portion of the website. Some seizure training, behavioral health training is going to come up out of that. And we are standing up a new EMS recognition program, a pediatric excellence recognition program. We don't expect to begin to take on EMS agencies until about this time next year. We're trying to get through all the paperwork and create all the applications and make it stand up this sort of EMS recognition program. And so that's coming down the pike. That's all I have for BEMSTS.
All right, thank you very much.
Thank you.
Next for discussion and action items. First we have, can I get a motion to discuss, amend, and approve the staff minutes from January 19th meeting? Two, first and a second in the room. Thank you. All right, if we can scroll through that. Those are in your packet as well as on the meeting invite. Are there any recommended amendments? Hearing none. Anyone opposed, please say nay. Any abstentions? All those in favor say aye. Thank you. Next up is, I don't think Dr. Patel has joined us.
This is Andy Ting. I'm one of the vice chairs for the COT, so I can give a report in his place.
That'd be great. Thank you very much.
Actually, there has been a change in leadership. Dr. Patel has finished his term, and now it's Dr. Jordan Weinberg. He's a trauma surgeon up in Phoenix. I'll connect him with Shelley later about obtaining membership on staff so that he can continue to give the report from the ACS COT. But in the meanwhile, the two things that I will relay is, number one, we had a state trauma grand rounds. This is something that we plan on doing quarterly. There was one that took place about 2-3 weeks ago and is well attended by multiple trauma centers and trauma members within the state of Arizona, and as well as a good number of attendees from other countries. They're using a simulcast technology to be able to participate in the discussions. There are 3 cases that were discussed and presented by by largely residents. And number 2 is there is going to be a meeting that takes place on June 28th. Consisting of many members in the trauma surgery community to kind of talk about how everyone can collaborate better and come up with ideas that can advance the patient agendas through the COT. That's June 28th. So that's the 2 updates that I have.
All right, thank you very much. Next, if I can get a motion to discuss, amend, and approve Trauma Program Recognition Awards, develop annual recognition program for trauma program managers, trauma medical directors, registrars, and injury prevention awards program. I see a first in the room. Thank you, Dr. Pfizer-Pond. Any second?
Second by Sandy.
Thank you, Sandy. All right, Noreen, I believe you are on the line.
I am. And as you can see on the agenda, there's a couple of ideas for the individual positions that we think should be recognized. And I guess we're looking for feedback from this group on, if there's anybody else that should be recognized and how the recognition process should be, established, whether it's a work group, whether it's, through STAB. So, we're open to suggestions. We were going to try to do something this month, because we did with the EMS providers, but it just wasn't enough time. So we're looking to maybe implement that next year at the same time that we do EMS Provider of the Year Award from the different regions. So any feedback that you have is welcome. And I guess we're looking from this group to discuss, amend, and approve moving this forward.
So to clarify, this is a service recognition award, much like what we just did with the state EMS provider. Is that right?
Correct.
That's correct. And, you know, when we EMS providers, when we looked at the trauma centers, there's so many facets to the trauma system that's really important. Program managers and medical directors, the registrars, the injury prevention. There's also outreach. Injury prevention and or outreach is more the upper levels. You know, I mean, injury prevention is required for the level 4s, you know, also, but the upper levels really, you know, have prevention programs. So, you know, any feedback or guidance that you can provide would be greatly appreciated.
This is Dr. Gamer. I've moved to move this initiative forward, but I do have a question.
Okay.
Is this going to be a regionally based, or just one recognition for statewide providers?
We really don't have that solidified yet, Dr. Gamer, because, you know, trauma centers, you know, there are so many in the central region, and you know what I'm saying, they're not evenly dispersed throughout the region. So
Okay.
any guidance that we could get from this group on how to push this forward in a fair way that gives everybody an opportunity to participate. And so we were thinking really through STAB.
My motion stands to move this forward. If there's a second.
Second.
Any further discussion? So I think looking at this, it sounds like this would be a statewide award for the different categories presented through STAB. I think that more adequately reflects the entire state. Most of the trauma centers may not participate with the EMS regional council, so I don't think going through the councils would necessarily represent them. I think this is a nice way to make sure we recognize people for the hard work. At the Bureau, we like it. We're the regulatory agency, so it's nice to do some positive reinforcement and acknowledgement as opposed to just regulatory function. So we appreciate the support from this committee. I'll go ahead and take a formal vote unless there's any further input. All right. Anyone opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
All right. Thank you. Motion passes. Next, Kim, just a demonstration.
Hi. Yeah. So I think a lot of you probably know by now that over the last several months, the state has been working with Image Trend to develop a license management system that is to help make things more efficient. One thing that I do think that is good to know is that there are two separate sites. One site is for the providers, such as the CON, ambulance, and EMCTs, and there's a separate site for the hospitals, which are just for the base hospitals and trauma centers. So just to be aware that there are two different sites that require two different set of credentials to log in. If you are a current trauma program manager or medical director, you've already been added into the system. If the need arises that you need to be added to the system, please contact me and I can do that for you. The protocol is I will add you to the system and affiliate you to your hospital. You will be sent an email that contains a link and your username. That link is only good for 24 hours. However, the most important part of that email is the username. So if you don't get that 24-hour window to use that link to reset your password, you can go to the EMS hospital portal site and click that forgot password. And it'll take you to a screen where it'll ask you your username, your email, and your last name, and then you can follow the prompt to create a password and gain access into the system. Once you gain access into the system, you will see your hospital affiliation. This test only has one hospital, but if you are affiliated with more than one hospital, they will be listed separately.
So on this, you will then see a view applications, and if you click the view applications, it'll take you to all of the applications that are available for your facility. This particular test hospital was issued a designation, one-year designation with a corrective action plan. That's why you don't see a full application here. This test hospital also is a base hospital. So since you only apply for a base hospital once, the base hospital application is not appearing for this hospital. But if you were not a hospital that is a base hospital, that application would appear along with all the others to apply. So, and we also have created several user guides that can guide you through how to navigate different aspects of the applications you're seeking to fill out. And that's pretty much how you gain access. And of course, if you have any questions for me, I can answer them. And if you have any, you don't have your username, you missed that email, just reach out to me and I can send you that link in your username.
Perfect. Any questions for Kim? Thank you for covering that. All right, next up, Vostel is going to share some ground level fall data. This was something that had come forward as a request. I know last meeting we had a presentation from the Arizona Fall Coalition about some of their outreach work that we're doing. And Vostel had pulled quite a bit of fall data, which we thought this would be interesting for this group to see as well. So I will hand it over to Vostel.
Good morning, everyone. I think several months before, a few trauma centers showed an interest in figuring out the falls is a really big problem in Arizona, and they wanted to see how many injuries we are not capturing, fall injuries, I mean, not capturing at trauma centers. Hence this report was developed with that purpose in mind. And for that, I had to actually do a hospital discharge database was used in order to do that analysis, obviously because we do not have non-trauma centers in our registry. So what we found out is that most of the fall injuries, it's treated by non-trauma centers. So if you see in last 3 years, not last 3 years, actually 2019 to 2021, in that 3 years, there were almost 200,000 injuries were treated by non-trauma centers compared to what we saw in trauma centers were total of 18,000. Now that again comes from the trauma center numbers comes from not from the ASTR, but hospital discharge database. So we coded as that if the hospital is a trauma center, we categorize them under the trauma center, but this does not use trauma registry. It is purely hospital discharge database. So in overall, 3 years, we had more than 200,000 falls in state of Arizona. So if you look at the chart, can we scroll down a little bit, Shelley? See that's good. So the blue is a trauma center, and then the orange is a non-trauma center. So it's like, we mainly over the year, from 2019 to 2020, we saw a decrease. And then again, it came back to, it's again going up. Can we go to the next table? So to get the figure it out, the distributions by age groups, okay, which age group is affected more. And if you see over there, 7%, it's only 7% in 0 to 40 years, okay, at the trauma centers. So, and whereas in the non-trauma centers, it is 28%, so which makes sense. Usually you do not see a severe fall injury among 0 to 40 years old compared to older age groups. So yes, trauma center is not going to see that age group that frequently. So if you see the on the right-hand side, that table which says percentage, it's only 7%, and then the 8% in 41 to 60 age group, and then 84% of what trauma center sees is in the age group of 61 year and older. Whereas in non-trauma center, the distribution is slightly different. And among the 0 to 40, we see 28%, then 16%, 41 to 60, and then 55%, 60%. So it's slightly different, a lot different, not slightly, in non-trauma center, the age distributions compared to the trauma center. We can go to table 3, Shelley. Okay. Then we looked at it, okay, what is the outcome of these patients, like, for example, what was the length of stays if they were admitted, and, what was the discharge status of that. So if we see the length of stay, how many patients were admitted in a trauma center and non-trauma center. So if we look at the percent-wise, 48% got admitted in the trauma centers, which again makes sense, okay, because trauma center being a trauma centers, more severely injured patients are going to come, whereas in non-trauma center, the admission rate was only 16%. And then the length of stay, the median length of stay in trauma center and non-trauma center, there was not much difference between the median, it was 4 days. And if we, let's go down to table 4. That table 4 just shows you the breakdown by if it is a level 1, level 3, and level 4, and then the percent in that. So what we saw at the when we just restricted only to the trauma center, level 1 show the 71% of the injuries were presented at the level 1 and 20% at level 4. So most of the falls injury presented at trauma center, 71% were treated by the level 1. And then by gender, if we see the distribution, male and female, at the trauma center, female 54% and male 45%. And in non-trauma centers, also the similar distribution. So slightly higher among female and at both the, whether it is a trauma or non-trauma center, it did not matter. The gender female was higher at both. And then we did table 6. It talks about the region divided into central, northern, southeastern, and western region based on the, so in hospital discharge database, we do not collect the incident county. So this is a residence county. So based on the counties, we divided into, but the residence county, we divided into region. And again, we look at, again, the right side of the table, which is a percentage of trauma center. And obviously the central region being the highly populated, we are gonna get more number of cases in the central region. So central region, and then north and southeastern region 17%, and the western region 3%. Okay, so then we look at the discharge status, what happened to these patients at the trauma center and non-trauma center. Then we see that at trauma center, 54% of patients were discharged home, whereas 82% of the patients discharged home at non-trauma centers, which again, that's the way it should be. Like, it makes sense that, okay, non-trauma center, the injury is less severe, 82% are getting discharged to home. So when we look at this SNF, ALF, and rehab, that's the percent, is going to be higher, way higher, like 35% in trauma compared to 13% in non-trauma center. So of course, more patients are going to get discharged to long-term rehab and that from trauma compared to non-trauma. And mortality is going to be higher. So if we see 2% mortality or almost 1.97% mortality at trauma center compared to 0.4% mortality at non-trauma center. So what this report actually, is saying is that yes, our non-trauma centers so do see a huge number of falls injury compared to the trauma centers. Like as we saw in the table 1, can we go back to the table 1? I want to really focus on that. Table 1 is that we have only total we have more than 200,000 injuries in that 3 years. 7% were present at trauma centers, and mainly most of those injuries were presented at non-trauma centers. So they do see, but when we saw the distribution difference between the two, what we found out is that the injury is less severe at non-trauma centers, which makes sense, but the burden is really significant in Arizona. It's like more than 200,000 injuries treated by non-trauma centers at fall injuries. And so that's what this report is about. Yeah.
Thank you, Vatsal. Any questions? I know that we have discussed this in this committee, that many of our ground level falls and hip injuries are not going to trauma centers and they go to community hospitals. And so they are captured different ways depending on what your geographic area looks like. If you're in a rural community, they may go to a level 4 facility where it's activated as a trauma, versus a large urban center where it may go to your local community hospital and not activate as a trauma. So sometimes we capture these patients in different buckets depending on where you are geographically and where the patient is. Certainly recognize that fall injuries and hip fractures are a large source of injury and morbidity and mortality within the state. Any questions or comments? Thank you, Vatsal. Next, I will turn it over to Anne for discussion of trauma triage 2021 guideline update.
Good morning, everybody. Shelley, would you like me to pull up and present or do you want to pull up the link to the document in the agenda? Either one's fine.
Either way, you tell me.
Go ahead. Why don't you pull up the link and then I can do the presentation for the next item.
All right.
Okay. Can everybody see Shelley's really good at remembering to make things bigger on the screen and I am not, so it's good she's presenting it. So I just wanted to go over, I know there's been some discussion in some of the different committee meetings about the newish trauma triage guidelines, and just also if you're connected with the EMS data or the data collection that we have through AZ peers and EMS agencies, you may or may not know that there was not an update to the way that we collect trauma triage criteria when the new version 3.5 came out, because there's such a long road to plan that version. So in addition to the fact that this is very important and there needs to be a way to collect the new 2021 trauma triage guidelines for EMS agencies, NEMSIS, which is the National EMS Information System that creates all the standards, put out something called a hotfix. And the particulars probably aren't super important for this group, but just in general, so you know, a hotfix is not something that waits till the next version that comes out. It's not something that has to wait to go through committees. So it is available now on their website for EPCR vendors to apply to their systems. And that means that agencies, when they move to 3.5, should be able to collect this information. They should contact their EPCR vendor just to double check. But they can collect it in 3.4, but it's a custom value, and those are a little bit trickier to get to come over. So that's the general idea. This page right here talks about E-injury 03, and then there's E-injury 04 in the next one. And the values are changing somewhat between the two versions. So I won't go through all of these, but this is available on the NEMSIS website, and we have the link in the agenda if you want to check it out more closely. And you can see that there, on the right side, there's a 2011, that's the older trauma triage label. On the left side, you can see it's the newer one. And it just says there's no change for the top two. Anything mapped to means there was a code change. So if you're collecting that, make sure you send the other one or collect the new proper one. If there's a brand new value that didn't exist in 2011, that's listed. And then when there's just a label change, so they changed the label somewhat, but the code didn't change, that's described there. So it's a nice visual walkthrough of the changes and how the changes will affect data collection. As Rachel mentioned before, all Arizona EMS agencies should move to version 3.5 prior to July 1st of 2023. And my understanding is that vendors need to have this available to agencies by no later than August. So we should be able to collect this new updated criteria for the agencies that are using them in 3.5. Are there any questions?
Thank you, Ann. So I think for those of you that may be looking at the data piece and kind of trying to figure out what we're talking about, it's pretty significant in that the field triage guidelines for trauma activations were changed at the national level, as we discussed in STAB last year. And so this is now going to match what is in the new trauma triage training. So the ACS updated their field triage guidelines. The education committee spent quite a bit of time putting together a really nice training curriculum, which is available throughout the state for agencies to implement to go live based on that. But the current documentation in NEMSIS 3.4 is the old version. So your trauma activation criteria matches the old activation criteria for 2011. So this is the fix to basically align with the new updated. So it's basically saying we've got NEMSIS 3.5 that had gone live prior to ACS doing their update. ACS has done their update, so this is now going to align with that. So it's kind of moving parts that happened. The two big national committees kind of worked overlapping on big updates, and then they kind of went live around the same time, and so NEMSIS has created this fix. For the trauma centers, I think this is going to be a big deal, so I wanted to get input from this committee because really we want to make sure that you guys are able to capture what the reason for the trauma activation is and why that patient was transported to a trauma center. So I wanted to give a little bit of background about that and then get some input from this committee.
Does this committee or anybody know what our level 1 trauma partners, what work they're doing internally to modify their own internal activation criteria to mirror these changes? I know I can speak for my level 1 trauma center on the east side. The trauma service has gotten together and looked at these changes and has made some modifications, and after and is now in sort of in the hopper to do education to our frontline, emergency department personnel, so that they're triaging their trauma patients appropriately.
So I know some level 1s, I can't speak for all of them. Some level 1s have kind of looked at the updates and are making some changes to their algorithm. The feedback that I've gotten from some centers is that this is really specific to the pre-hospital activation versus the hospital activation, which I do appreciate. But I use the example of the fall height is significantly changed in the newer version. And so if a facility doesn't activate for a 11-foot fall, but EMS is specifically coming to you with an activation for 11-foot fall, that's where if you don't match the two, it can become a little bit confusing for the field personnel as well as the hospital personnel. So hopefully more facilities will come on board with that. But I do know other centers are doing the same that your hospital has. So I've gotten some feedback from other facilities that they feel that this is specific to pre-hospital.
Yeah, this is Andy Tang. Yeah, to speak to from the level 1 trauma side, Gail, what he said is right. This is largely an EMS, field triage protocol. Of course, as a level 1 trauma center, I'll speak for my trauma center specifically. We did look through all of the changes, and specifically referring to, Gail, what you were talking about with the fall height change. We looked at our internal data from the past 5 years, and all level 1 trauma centers are required to review their activation criteria from time to time, just to make sure that things are appropriate. The way the resources are utilized is wise. So based on the recent change in the field triage, we did look at our internal activation criteria, and we looked at the data between less than 10 feet, 11 to 15, 15 to 20. And to see if that more granular breakdown resulted in any reason to change our activation criteria. And based on the data that we looked at internally, at least specific to our program, it didn't warrant any changes for our internal activation. The other thing is, different trauma centers have different activation algorithms. And also, for example, we have 3 levels of activation. Some centers only have 2 levels, and so I think it's a little case by case.
Thank you, Dr. Tang. So I think, we really wanted to make sure we brought this discussion to this committee because there is going to be some transition with data for the EMS agencies. They will have to obviously train their personnel if they're using these new criteria. But it is nice to see that BEMSTS was able to make this update just because we've done so much training with EMS statewide on the new activation criteria from a pre-hospital perspective. And so we really wanted to make sure that there's the ability to document that matches with that as well. So thank you, Anne, for sharing that. Just quickly before we move to Anne's next summary, I did see Dr. Trika's comment in the chat regarding time to look at potential injury prevention regarding falls. I think it's a very good point. That was part of the Arizona Fall Coalition presentation. We did take that to the Education Committee last round. At that time, they had tabled that, but we can definitely take that back as a request from that committee to see if education can look at potentially putting together some training curriculum. So I think there is quite a bit that EMS can do, having worked with some community paramedics and programs that that kind of go into people's homes. A lot of that training really can be applied to any 911 unit as well. When you go in for a fall injury and the patient's next to a small, area rug that they tripped on, discussing with the patient, can we roll the rug up, move that out of the way for you? There's small little interventions that can be trained pretty easily for the EMS community. So we will take that back to the Education Committee. So thank you for bringing that up, Dr. Trika. And I'm going to hand it over back to you for the next item. Thank you.
Hello, everybody. I'm gonna hopefully be sharing my slide presentation. Can you let me know if you can see this on the screen?
We can.
Oh, good. Okay. Because once I go to slide presentation mode, I can't see any of the other stuff, including the screen that I have for the meeting. So I just wanted to go, this is a fairly short presentation. There's a longer one with a lot more detail available on our website. I'll show you the location at the very end of this presentation, but I just wanted to go over just a summary of the key changes as far as some key data pieces that have changed for 3.5. We are currently in the process of transitioning, and I know I mentioned this before, but some agencies are doing 3.5 right now, some are doing 3.4. If you're a hospital, you may see on run forms or PDFs a combination of slightly different information. So did the slide change to my next slide?
Yes.
Oh, good. That's always the problem. Okay, so one of the questions, and there's many questions that we tend to ask that 3.5 is meant to improve our ability to answer. So what kind of call was it? They've improved the type of service requested to, for example, they split interfacility transport into 3 different subcategories, and they've added some additional subcategories to allow us to better understand what type of service was requested, what type and level of response was there. I'll talk about something on the next slide too that plays into this, but we had primarily relied upon a value or a variable that wasn't really answering this question. It was primary role of unit. So that one has actually changed, and it's unit transport and equipment capability. So not so much what was the level of response, but what is that physical unit capable of providing as far as care. Unit on scene and patient contact. If you were familiar with the data before, we had one data element was called incident/patient disposition. It's split into 5 now. I know that sounds terrifying, but it's much better because the answers are much shorter. And once everyone gets used to it, I think a lot clearer because each part is divided out instead of having these values that ended up being like sentences with multiple commas, which is not really good for field collection, in addition to the fact that there were some things that you just couldn't document, which also didn't make sense. So they replaced that with unit disposition, which basically is like, did you have a patient contact or did you not? And if you can record canceled calls there. And then if the patient was, if there was a patient where they evaluated and treated, obviously we always want to know that. So that part of the disposition was replaced with a new disposition variable called patient evaluation and care. And this is going to allow documentation of, were they evaluated but no care provided? Did they refuse evaluation and care? Did they get evaluated and refuse care? That kind of thing. There were some custom values that agencies were using, and it's not always clear when they're using them to them that there wasn't the ability to document everything, but there were actually some values that didn't exist until now that we really needed. Then what did the crew do? So before, this was also super confusing. I mean, every state is different and we had to make this work for every state. And in Arizona, we really had a hard time telling sometimes what exactly happened. So this one is going to answer things like, did the crew provide primary care to the patient? Or did they assume primary care from another unit? Or did they help out with assistance or a supplemental care to a primary unit? So those are the kind of things that we should be able to break out with that, which is really nice. Was the patient transported and which agencies were involved? So that's another one that is hopefully a lot clearer with transport disposition. And especially because of the, we have a lot of fire-based EMS where there are ambulances involved, and it's kind of hard to know who did what and who went with whom. So you can basically say, I transported the patient with my crew. Another agency transported the patient with myself and my crew on the ambulance. I transported the patient with a member of another crew, or no, there was no transport. And then lastly for, oh good, it went. The 5 disposition split is if there was a refusal, like a refusal of care or refusal of transport, why? And it breaks down everything from, you know, if it was AMA or patient felt they didn't need to go or those sort of things. And we've already kind of discovered there's maybe a value that should be added to that, but it's still much better than what we had before, where really there wasn't a very good description to tie in with everything else. So earlier on the first slide, I mentioned when they are changing the primary role of unit to the equipment, that there was another, this is a brand new variable coming into play in 3.5. And it is what level of care was actually provided. We've always had a really hard time answering that, and it seems like such a simple question. So the new variable that has been added is level of care provided per protocol, which is to me really important. It has nothing to do with billing. It has to do with when you actually got there per your protocol, what level of care did you provide? So I'm really hoping that will help us break down some of the questions that we've gotten over the years that we really have been unable to answer easily. And then how ill was the patient before and after EMS care? There have been some changes and additions to initial patient acuity and final patient acuity. There's a new variable. Obviously, it would only be for interfacility and medical transports, but it's a pick list asking for reason for interfacility transfer medical transport. So it's more general categories, but I also think this will really help us sort out kind of what's going on and why. And then lastly, for this presentation, if transported to what type of destination and why. So they added improvements to, these are not new variables, but they've added values to them. So type of destination, for example, before it just said rehab, but it didn't, that actually was meant as physical rehab, and it got misused a lot as, you know, substance rehab. They've added a mental health facility one. So there's some values that were really needed to be added. And then capability, hospitals obviously can have more than one capability or reason you're taking them there. It might not just be the trauma. It might be, you know, a cardiac arrest or something in addition to that. So it allows now for agencies to collect more than one capability of the hospital that is the purpose of their reason for going to that particular hospital. And then that's it for my summary. I wanted to, let's see if I can get out of here. Okay. I just wanted to show, I pulled this up. So you guys probably are familiar with our public facing webpage. This is the one under data quality assurance for AZ peers. There's a ton of resources I post here, and I keep trying to go just so you can see this tab. Okay. One of the tabs is 3.5 transition information and resources. There's a lot of things, but I just want to point out if you want more details about these changes, There's a longer presentation that's posted right here that you can review that has a lot of interesting information, but it's quite long and too much for this meeting.
Thank you very much, Anne. I appreciate it. All right, next, discuss go live of ACS resources for optimal care of the injured patients. I don't know, Kim or Noreen, if you wanted to handle this action item or this discussion item, I should say.
Dr. Chang.
Hello?
Yes.
Did you call my name?
I did not, but Kim volunteered your name.
Oh,
I just didn't know if you had specifics on the dates of the rollout for the new gray book. I believe it was a September date for virtual
gray
review.
book- I'm sorry, I apologize. The gray book has been out already. I know there's continued updates, but it's been out for, geez, I want to say,
I think it's March. Or something.
yeah, it's right. Well, like I said, there's been updates, but you know, the gray book was released actually well before March. But yeah, it's available now online through the ACS website.
Thank you. And I think the main thing we want to make sure for all the trauma centers is just an awareness that there is the new book. I think everyone should be aware of that as part of your trauma updates, but there are some definite changes compared to the previous book in terms of requirements for the trauma centers. So we want to make sure that this committee, since staff falls under ADHS and the regulatory body, that we do mention that there's an update to that book that came through.
Yeah, absolutely. And if you go on the ACS website, there's actually tutorials on what some of the significant changes are between the orange book and the gray book. Yeah, but there are the gray book is actually significantly more succinct compared to the previous version, the orange book. Very bullet pointed, chapters. But yeah, there has been some changes, and some areas are fairly significant with requirements for verification.
I think most notably, a lot of that has to do with FTE requirements that are going to increase those requirements and financial responsibilities to the trauma centers. And the standards will go into effect for visits starting in September of 2023. So forward from that timeframe, those facilities after September of 2023 will fall under that gray book. All of them that are happening before then will still be under the old orange 2014.
Yeah.
Thank you both for that update. And I do see in the chat, thank you for sharing, there is a link that was added in the chat for anyone who would like a hyperlink to the updated changes. And it looks like, thank you, Jen, I see changes made since the initial release as well. All right, next on the agenda is discuss the future of the Arizona State Trauma Registry. I'll hand it over to Chief Garcia.
Right. Well, we wanted to take a little bit of time out of the agenda today to talk about the future of the State Trauma Registry, and wanted to share that we are in the process of renewing our contract for the current trauma registry, which is supported by ESO. We have every indication from the vendor that they will be on contract with us through June 30, 2024. We've also asked if they'd be willing to stay on with us 1 year in addition to that through June of 2025. They have indicated, ESO has indicated that they intend to phase out the Trauma One product. So we know we will not have the registry in its current format forever. But we wanted to share with everyone that as of right now, in our contract negotiations, we are under the impression that we will have the registry at least through June 2024 and hopefully 1 year thereafter. So at this point, knowing that ESO has notified all of the states and many of the hospitals that they will not be supporting Trauma One forever, we know it's time to start talking requests for proposals and going out for bid for a new trauma registry. To be clear, we have not started the RFP process. We have not formally entered an RFP process for a new trauma registry, but we know it's right around the corner and we want to get started with that. So as we take our next steps and begin discussions with state procurement on that formal process, we want to make sure that we are keeping all stakeholders informed, and especially when it comes to the advisory board, we want to make sure we're also collecting some feedback from you all in what is most important to include in a trauma registry. And so as we do begin to develop a scope of work for a request for proposals, we will, of course, be soliciting input from staff and asking what is the most important to include in that RFP process. So you can expect from us that follow-up will be asking for some more information through a survey from all of our staff members. And we want to make sure that everyone knows that as we step through this process, we will absolutely be looking at any proposal, any bid that comes into the department. Cost, of course, I have to say, will be weighed. We don't have an unlimited budget, as you all know, but it won't be the only factor that we are looking at in this process. It is so important that we get some input from this group and that we're able to weigh all of the most important criteria as we look at the future of the trauma registry. So with that, I know there's a question.
Yeah, let's see, Dr. Notrika, you have your hand up.
Yeah, so I think that we all need to be prepared with the alternative because the numbers that we initially had heard for continuing with having a trauma registry are unaffordable, both for the centers and for the state. And I think that instead of simply saying, all right, we're going to take RFPs and we're going to do this, the backup plan, unfortunately, would be no longer participating in a trauma registry and no longer using the ACS. And I know that sounds incredibly radical to the people in the room, and there are two aspects of it. One is if we don't have that as our best alternative to a negotiated settlement, then we are obligating the trauma centers to a six-figure registry costs, which is, not to mention the cost to the state of Arizona, but the cost to the numerous trauma centers that we have in the state. It's unaffordable. That gives us 3 years 2 years to figure it out. But I would strongly advocate that if we cannot get the terms to something that we feel is sustainable as a state, that we need to look at the alternative, and the alternative being no registry and pulling away from the American College of Surgeons. I will tell you that if we go that way and the American College of Surgeons loses however many trauma centers we have in Arizona, they may also reconsider whether or not we are being used. We are being mistreated in a way that's not economically feasible for the member institutions, and they may have to look at it as well. But please don't take that off the table, especially as we do this negotiation.
Yeah, and Dr. Notrika, this is Rachel again. I appreciate your comments because for many of us in the room and on the line, we have seen some estimated costs that were shared with many states and many of the hospitals across the nation by one of the vendors. So I can appreciate your comments. What I do want to offer, though, is that for our discussions so far with our current vendor, ESO, they have offered the state a very affordable option that will not pass on any additional cost to the hospitals participating in the trauma program. And so for the next year and hopefully the year thereafter as well, we do not expect any increase in costs that would be passed on to any hospitals participating in the trauma program. Secondly,
I'm sorry, to clarify, what you're saying is that the state would buy it and then the hospitals would be able to use it at no cost.
To clarify, Dr. Notriga, for our current product, that is Trauma One, which we contract with ESO for our current product, which we expect to have for 1 to 2 additional years at this time, of course, no increased cost. The vendor has been very reasonable with us, and we have every reason to believe that as we go out to bid, that all of the vendors, especially the top 2 that we all know and have heard about, would submit competitive proposals to the state. So it looks like we are going in a direction that will be much more affordable than many of the states and hospitals were previously led to believe in the last year. I really have my fingers crossed that based on our discussions so far, that we will be able to find an affordable option. I also want to point out that once we step into that competitive bid process, once that begins, the state does not have any authority or ability to pass any of the trauma registry costs on to hospitals. We would not intend to do that. We are absolutely looking for an affordable option that could be implemented across the state. And to take it one step further, for hospitals that do have customization already in their registry, they would not be required to adopt a new product. We would be working much like we do on the EMS registry side to ensure that any existing systems could link up to a new product. Does that help at all, Dr. Notriga, to clarify?
Oh, absolutely. And I'm very impressed that you're getting that what you're getting from them is so different than what we were initially, assaulted with. Thank you.
May I ask a question?
Yes, just 1 second. We've got a few people in line, if you don't mind.
Yeah.
And then we'll get to you. So I do see in the chat from Eric Cooper just regarding the request to provide input on the ADOT construction plan. So just a plug for that in the chat if you've not looked at that. And also see the comment from Noreen regarding trauma center participation in the registry is required in statute. So again, that is a key piece. The Bureau cannot ever waive statutes, so just putting that out there. And then Debbie, I know you are next in line, so I'll turn it over to you, and then we'll come back to Dr. Tang. Thank you.
I was just going to mention that it's in statute as well.
All right. Thank you, Debbie. All right. Dr. Tang?
Yep, thank you. Sorry about that. I didn't realize there were people in line. My apologies. My question is, I just want some clarification. Trauma One is going defunct in a couple of years. For now, there will be continued support without more monetary input from the individual hospitals who use the program. With the new product that's going to replace Trauma One, am I hearing this correctly, that the state will purchase whatever program it decides on eventually as the best option, and the cost will not be passed on to the individual hospitals? As in, I want to clarify at this point, when the new program is eventually designated, will the individual hospital have to upgrade their system to this new program and pay the associated cost, or does that come from the state? I got confused with that point.
Dr. Tang, thank you for your question. As we step through the formal RFP process, the costs that we are soliciting from these vendors are to understand the costs that will be for the state to implement the new trauma registry. The maintenance and ongoing costs of the state trauma registry will be covered by the state of Arizona. We are only able to really look at those costs. And with respect to any costs that would be required for maintenance from the hospital side, that is something that we could make sure that we ask about during the RFP process. But our intent would be to make sure that any costs that are included in the RFP are for the state and not for the hospital. I hope that answers the question. I think I saw that there might be a question in the room as to that end.
So currently, the hospitals have to pay an annual subscription fee for that software. And if they have unique financial flat files, that's an additional cost. So there is some hospital cost. If you could help us determine that before we lock into something that's going to be outrageously expensive for the hospital systems, that would be appreciated. Thank you.
Yeah, and that's absolutely something that we want to take into consideration. I know for, it sounds like Vince, you're describing level 1 trauma centers that have
And
those
level 4
agreements in place. We want to make sure that as we do go out to bid, that there is an option for folks that do not have any funds to spend on this program, that there would be a license and support available to those entities to be able to participate in the program. That's something we will ask for in our solicitation process. And to that point also, Vince and Dr. Notrika, Dr. Tang, if you all have input for us on what absolutely needs to be included as we prepare to go out to bid, we want to know what are those key components, especially when it comes to the financial impact here. What are those key components that really need to be considered in this RFP process? That is why we want to make sure we share a survey with you all. We don't want to miss those important aspects. I will say that it's become very clear to me over the course of our discussions in the last year that there are some centers, especially level 4 trauma centers, if I'm hearing correctly, that absolutely cannot afford to take on any additional cost in a transition to a new registry. And so again, we will make every effort we can to ensure that those costs are as transparent as possible up front, and that we have a good understanding of what we're stepping into with any transition to a new registry.
Noreen, I see your hand up.
Yeah, just to be clear, to use the State Trauma Registry, there should be no cost to level 4s. So if you're being billed for the product, please let us know and we can handle that with the vendor. Also, the costs usually associated for level 1s and those that are ACS verified are usually imposed by the National Trauma Database membership. Also, any customization that has been done to the product that the hospital requires. So the base model for Trauma 1 currently and moving forward, there should be no cost. And there shouldn't be any cost at all for level 4, unless they want to modify the existing program.
All right, thank you. We are going to quickly need to go to the last agenda item here for the discussion action items. If I can get a motion to discuss and approve forming a work group to review the bylaws. This is a requirement that we do every 3 years. We tabled it at the last meeting. If I can get a motion, thank you, Franco. First, is there a second?
Second.
Thank you, Dr. Southworth. So essentially, we just need to get approval to form a work group to review the bylaws. We promised to make this painless. We will combine all committees together, so that way we can, if you're on more than one, you don't need to attend 3 different meetings or 4 different meetings for this. So you need to approve forming that. Is there anyone that would like to participate? You can always let Shelley or myself know after the meeting if you're interested in participating in that. Yes, for a vote, anyone opposed, please say nay. Any abstentions? All those in favor say aye.
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 Thank you. And again, if you're interested, just let us know. We will get you added to that fun work group. All right, next agenda item is any items to consider for future meetings. If you have anything you'd like to have added to the agenda or discuss, please share with myself or Shelley, and we will make sure that we include that. I'll call to the public. All right, there is a list of upcoming events in your agenda. If you're interested, you can also go to the Bureau's website where we have a number of upcoming events. Our next meeting will be September 21st at 9 o'clock in the morning, hopefully in the same room. And if I can get a motion to adjourn, please. Thank you. All right, thank you everyone for participating. Thank you.